Okay. Hi, everyone, and welcome to the fourth part in an equity webinar series from GIN North America. So today we are pleased to welcome four speakers who are going to discuss their recent and ongoing work regarding the impact of clinical algorithms on racial and ethnic disparities. My name is Kate Carroll. I'm a member of the GIN North America Steering Committee, and in my day-to-day, I am the Director of Clinical Guidelines and Population Health at the American College of Physicians. I'm very happy to serve as your moderator for this session. So before we dive in, I would first like to share some highlights about GIN North America. GIN North America is a regional community of the Guidelines International Network and has been since 2010. GIN North America was actually the first regional community of GIN, and the aim is to provide a network for North American guideline users, developers, and others to form partnerships, collaborate, and discuss regional guideline issues. The membership consists of guideline developers, adapters, implementers, in addition to systematic reviewers and researchers, all coming from Canada, Mexico, and the United States. To accomplish these aims, we organize a webinar series, regional events, virtual coffee chats, and other opportunities to meet, share, and collaborate. So if you are not as familiar with GIN and checking things out, we really do urge you to go to the website. And if you are not a member, please consider joining, as GIN is a truly wonderful way to access resources and participate in a much larger global community that is committed to trustworthy and accessible guidance for better health. For new and existing members, please make sure that you create an account for GIN Connect, which is the networking platform for GIN members, and it's the best way to stay on top of the latest offerings from the GIN community. And in a bit, I'll drop some links in the chat to both GIN Connect and to the GIN YouTube page. A reminder that registration is open for the Global Evidence Summit, which is taking place in Prague, which is pretty cool, from September 10th to the 13th. This is the second summit and a unique opportunity for colleagues across the globe to meet and exchange ideas about how to best produce, summarize, and disseminate evidence to inform policy and practice, with the ultimate shared aim of improving lives. Early bird registration is still open and it closes June 13th, and so we really encourage you to take advantage of that. A few housekeeping items. Please note that this webinar is being recorded and will be posted to GIN's YouTube page after. Please stay on mute to ensure a nice, easy listening experience for other attendees. We're also requesting that attendees keep their videos off. We will have some time for questions after the presentations. Please use the Q&A option to share your questions. You should see that box right next to the chat box in the Zoom control bar. Now I'm delighted to introduce you to our speakers today. We have Mr. Brian Leese, who's a health policy researcher with Penn Medicine's Center for Evidence-Based Practice. His research focuses on the comparative effectiveness of clinical care processes, therapeutic interventions, and health system policy. And his work informs clinical and operational decision-making by Penn's health system leadership. He's also the Associate Director for the ECRI-Penn Evidence-Based Practice Center, which conducts systematic reviews on topics of national interest for ARC. And in 2019, he became the co-director of Penn's Cochrane Affiliate Center. Prior to joining Penn, he spent time as a researcher at both Thomas Jefferson University's College of Population Health and the American Board of Internal Medicine Foundation. Dr. Jennifer Lin is a board-certified practicing general internal medicine physician in primary care with Northwest Permanente and the director of the Kaiser Permanente Evidence-Based Practice Center. She's also a professor in Kaiser Permanente School of Medicine. Her career interests have focused on evidence-based medicine and healthcare policy in primary and preventive care. She serves as the Evidence-Based Practice Center's principal investigator on U.S. Preventive Services Task Force contracts for systematic reviews, methods work, and portfolio management. She's recognized by her peers as an expert in systematic review methodology, evidence-based medicine, and clinical prevention. Dr. Lin recently completed her term as a member of the American College of Physicians Clinical Guidelines Committee, which I'm very sad about, where she contributed to its method subgroup. And she's also a non-voting member of Kaiser Permanente's National Guidelines Committee. Dr. Shazia Sadiq is a gastroenterologist and health services researcher at the University of Pennsylvania. Her research, clinical expertise, and quality efforts aim to promote the integration of evidence-based practices into clinical care. She serves as the Associate Director for Research for Penn's Center for Evidence-Based Practice and has worked with AHRQ's EPC program since 2019. And she also serves on the Clinical Guidelines Committee for the American Gastroenterological Association. And lastly, Ms. Kelly Tipton is an accomplished public health professional and research methodologist with over 15 years of experience in conducting comprehensive reviews. Ms. Tipton is the Associate Director of Clinical Evidence Contracts at ECRI, where she plays a pivotal role in leading and co-leading evidence reviews. She also serves as the Patient Engagement Specialist for the PCORI Healthcare Horizon Scanning System. And prior to joining ECRI, she was project manager for the University of Wisconsin-Milwaukee's Garrett Lee Smith Campus Suicide Prevention Project. Throughout her career, Ms. Tipton has demonstrated an unwavering commitment to improving healthcare, and she remains dedicated to ensuring healthcare decisions are evidence-based, patient-centered, and equitable. So that we'll get to the really good stuff very shortly. The disclosures for the panelists and myself are up on the screen. I can speak for myself. My partner is employed by a personal injury law firm that sometimes works on medical malpractice cases that may cite or refer to clinical guidelines in support of their case. And I will turn it over now.
Thanks so much, Kate. It's really an honor to be here. So briefly, in terms of our group's disclosures, the main thing we wanted to relay is that the majority of the work that we're going to be discussing today was funded by the Agency for Healthcare Research and Quality. We're very appreciative to AHRQ for their support of this work, both through contracts and methods funding. As was mentioned, a lot of Jen's work also is used to inform the USPSTF, and I serve on the AGA Clinical Guidelines Committee. So without further ado, we'll get into the overall outline of this talk. So this talk will spend, the first part of it will review the current state of algorithms. What do we know about the impact of algorithms on racial and ethnic disparities, as well as what strategies have been developed to mitigate racial and ethnic bias in healthcare algorithms. Then we'll discuss guidance for assessing algorithmic bias and fairness in clinical algorithms, and we'll end with a Q&A session. So first, we'll discuss the background of this work. As many of you know, there has been a long history of race and ethnicity utilized in medicine. And what we've learned over time, and there's been greater awareness over time, is that race really is a social construct. Population genomic studies have shown that there is greater genetic variation within one racial category than amongst racial categories. And race instead is identified and classified based on 1 to 2 phenotypic characteristics. This is evidenced by the fact that it is defined differently in different countries, and even here in the US, social categories of race have evolved over time. Ethnicity refers to social groupings that are based on some combination of shared language, history, religion, and culture. They can overlap with race, but not always. But both race and ethnicity are poor proxies for genetic ancestry, and differences in outcomes of disease should not be attributed to differences purely based on genetic predisposition or biology. The misuse of race and its socially constructed categories in medicine has contributed to inequalities. So as we start to think about the importance of terminology, we realize that each of these different areas can lead to problematic race-based decision-making, from semantics to discussing prevalence across racial and ethnic groups without context, to race-based diagnostic bias, to using race as the basis for pathology inaccurately, to race-based decision-making. And when we speak about semantics, one example is that we continue to use antiquated terms such as Caucasian. We also often use imprecise labels such as African American to really describe anyone with African ancestry without distinguishing between first and second generation immigrants from the Caribbean or Africa, or those whose ancestors were enslaved in the US. And these are obviously very heterogeneous groups of individuals as well. prevalence without context. So essentially, when people present racial and ethnic differences in the burden of disease without really providing context as to who are these patients and why that might be in terms of their countries of origin, what is the pattern of disease in their ancestry, as well as historical and sociopolitical forces that may shape differences in prevalence. Next, race-based diagnostic bias. This is really the crux of the issue, where portraying race itself as the biologic causal mechanism can lead to diagnostic bias. For example, in medical school, many of us were primed to perceive certain diseases, such as cystic fibrosis, as a disease affecting only one racial category, and in this example would be white individuals. There is a similar example of sickle cell anemia for Black individuals, but then that can lead to heuristic biases where we see a patient who fits all of these criteria. We have diagnostic testing available to diagnose them, but unfortunately, there are a lot of examples of diagnoses being delayed as a result of these heuristic biases. So one of the questions we get asked often is, why do we continue to collect data on race and ethnicity then? Data collection is still essential to mitigating well-established unequal care in society due to structural, institutional, and interpersonal bias and discrimination. There are many examples from the landmark Institute of Medicine and National Academy of Medicine report, which include that Black, Indigenous people of color, or BIPOC individuals compared to white patients, are significantly less likely to receive many services, and including adequate pain management for the same condition, or to be referred for a kidney transplant for end-stage renal disease patients. And we'll talk a lot about that in this talk today. So race-based clinical decision-making is a predictable outcome of the inaccurate use and interpretation of race. And we see this both in algorithms as well as in clinical guidelines. And so this picture on the left, some of you may have seen this, very famous example of this group of twins who each have one Black parent, one white parent. And when you apply the kidney function equation, also known as eGFR, or estimated glomerular filtration rate, in order to look at their level of kidney disease, if the patient identified as white, the eGFR for the exact same creatinine would be 21. But if they identified as, if they identified as Black, it would be 21. If they identified as white, it would be 18. And this difference is a significant distinction that magnifies the well-established racial and ethnic disparities seen in renal transplant referrals. And if the patient identified as both racist or mixed race, then the clinician would have been left to arbitrarily make a decision. And then when we look in other clinical subspecialties, in my field in gastroenterology, there are also several examples in which we make clinical decisions based off of race, including liver cancer screening. So after this historic or seminal piece was published in the New England Journal of Medicine, which is shown at the top of the screen by Vyas and colleagues, called Hidden in Plain Sight, Reconsidering the Use of Race Correction in Clinical Algorithms, the government took a strong interest in further exploring issues relating to algorithms. And so a congressional letter was sent from several members of Congress requesting that the Agency for Healthcare Research and Quality further explore this area. And they ultimately commissioned a systematic review that was contracted to our team at ECRI and Penn. And so today we'll be spending the first part of the talk discussing the findings from this report, which is publicly available on the website as shown here, and last month was published with an updated search as well in the Annals of Internal Medicine. So the two key questions that we looked at for this review were, what is the effect of healthcare algorithms and related tools on racial and ethnic disparities in access to care, quality of care, and health outcomes? And the second question was, what is the effect of interventions to mitigate racial and ethnic bias in the development, validation, dissemination, and implementation of healthcare algorithms? So just up front, we'd like to define a few key terms so that we're all on the same page as to what we're discussing throughout this talk. First, an algorithm is defined as a mathematical formula or model that combines different input variables or factors to inform a calculation or an estimate, such as an estimate of disease or risk of a particular health outcome. Algorithmic bias is the differential performance of an algorithm in different groups, such as racial or ethnic groups, due to intrinsic attributes of the algorithm. And when we talk about risk of bias, that is relating to the studies, the likelihood that a study's reported results are misleading due to methodologic issues in study design. Very familiar to this group, I'm sure. So this is the analytic framework that we utilized for our key questions. As you can see here, our population of interest included any patients whose healthcare could be affected by algorithms. Next, we list our interventions and comparators of interest for each key question, followed by our 3 categories of outcomes that include access to care, quality of care, and health outcomes. We also recognize that algorithms could be used in a wide variety of settings and have listed settings of interest here at the bottom of the figure, such as hospital, ambulatory, or non-clinical sites as well. Additionally, I'll add here that in the beginning of our process, we envisioned that we would only include race-based algorithms, meaning that race or ethnicity were used as explicit inputs into the algorithm. But during our topic refinement process, it became clear that algorithms without these variables could also contribute to racial and ethnic differences in outcomes, and therefore we expanded our scope to include both algorithms with race and ethnicity, as well as algorithms without. This is our study flow diagram to provide a sense of the amount of literature identified during initially first a year period, and then our search was updated by another 9 months after that. Our team screened 13,256 records at the full text level, and we reviewed 380, that was at the full database, and then at the full text level, we reviewed 387 full text articles, most of which were excluded. Ultimately, we included 63 studies, 17 for key question 1, 49 for key question 2, and 3 for both key questions. So in terms of how we classified studies by key question, as was mentioned, key question 1 included studies that evaluated an algorithm's effect on health or healthcare outcomes stratified by racial and ethnic groups, whereas key question 2 included studies intended to develop an intervention or strategy to mitigate either racial and ethnic algorithmic bias or a known racial and ethnic disparity associated with that algorithm. And we did have 3 studies that overlapped both key question, and they had to have done both of these 2 components within the same study. Next, I'll pass it off to my colleague, Kelly Tipton, to discuss the findings for key question 1.
Okay, thank you, Shazia. So I'll spend a little bit of time, as Shazia mentioned, providing an overview for our findings for key question 1. So for this key question, we looked at the effect of algorithms on racial and ethnic disparities, and there were 17 studies that we included. We found evidence that algorithms reduced disparities in 5 studies. An algorithm had no measurable effect on disparities in 1 study, and we identified 11 studies that showed algorithms which perpetuate or exacerbate disparities. Overall, studies were appraised at moderate to high risk of bias. So first, we'll discuss the algorithms that were shown to reduce disparities. There was 1 study examining an algorithm focused on kidney transplant suitability, and this is known as the kidney allocation system. This study here was a pre-post study, and of note, the kidney allocation system does incorporate race as an input variable. The primary outcome was waitlisting rate, and the authors found that disparities were reduced after the kidney allocation system was implemented. Then there was a study looking at lung transplant suitability, and similarly, it was a pre-post study. It examined the lung allocation score, which does not include race or ethnicity as an input variable. Now, the primary outcome here was waitlisting ineligibility, and the authors found that disparities were reduced for this outcome after the implementation of the lung allocation score. Now, next we have 2 studies that assess the effect of prostate cancer screening risk tools. And the tool studies were the Kaiser Permanente Cancer Risk Calculator and the Prostate Cancer Prevention Trial algorithm. Both of the algorithms included race, and both had as their primary outcome the number of biopsies avoided and clinically significant prostate cancers missed. And then finally, within this category, the last study compared the 2020 CHA2DS2-VASc score threshold with a 2014 version. Now, neither of the versions incorporated race as an input variable. And the score threshold itself is used to inform decision-making for anticoagulation for patients with atrial fibrillation. The study here used a modeling approach, and they demonstrated a potential reduction in stroke rates in Hispanic patients. So across these studies, the takeaway is that there were existing disparities in these clinical conditions, which were identified and outlined prior to algorithm development and implementation. So these algorithms were implemented as part of an intentional effort to tackle disparities. Next, there was one study which examined an algorithm that had no statistically significant effect on disparities. Now, this algorithm informed emergency medicine triage, and it was for chest pain, and they did this via the heart pathway. The study itself was a multi-center pre-post study, and the heart pathway of note does not incorporate race or ethnicity as an input variable. The primary outcome here was 30-day death or myocardial infarction. And so the findings from this study, the takeaway is that the heart pathway itself did not significantly impact death or MI rates for BIPOC individuals. However, the authors found that non-white patients and women were more likely to be classified as low risk and discharged early, but the longer-term implications have not been assessed. Now, we also found it interesting here in this study is that non-adherence by providers to the pathway, as authors reported, was higher for women, but non-significant for non-white individuals. The reasoning behind why that is was not discussed or further analyzed there, but it may provide some insight into pragmatic challenges of algorithm implementation. So our third category, we identified 11 studies which examined algorithms that were found to perpetuate or exacerbate disparities. And most of the studies examined algorithms to triage patients by acuity of care. So for starters, we found 2 studies examining the use of the Emergency Severity Index, either alone or to inform a care pathway. And it was used to triage patients presenting to the emergency department. The findings of these studies, the authors indicate that when using the algorithm either alone or to inform a care pathway, non-white patients were more likely to be inappropriately deprioritized for care. So non-white patients that may have the same level of need were more likely to receive a lower acuity score, indicating a less urgent need for care. Now, the authors also suggest that lower scores may reflect true differences in illness severity between patients upon presenting to the emergency department, as opposed to the impact of the potential impact of provider assessment, but further research here is needed. There were 4 studies still within this broad category of algorithms shown to either perpetuate or exacerbate disparities. We identified 4 studies that looked at the outcomes of applying severity of illness scores. So, for example, such as the SOFA score or the Apache or other scores. And they were applying these to be used during crisis standards of care. Specifically, there were proposals from professional societies encouraging the use of the scores for scarce resource allocation during the pandemic. The takeaway from these studies is that authors found that applying the severity of illness scores outside of its original intended application resulted in less resources for BIPOC individuals, thereby leading to disparities or possibly exacerbating existing disparities. Next, there were 3 studies comparing prediction models used to inform lung cancer risk. Now, all 3 studies compared the PLCO in 2012 equation with the USPSTF 2013 or 2021 prediction models. And these inform their guidelines for lung cancer screening eligibility. Now, in this case, the USPSTF model does not incorporate race or ethnicity as an input variable, whereas the PLCO 2012 model does include race. Now, the takeaway is that all three studies found that the USPSTF models resulted in higher proportions of Black patients being ineligible for lung cancer screening. However, the studies were not pre-post studies, and then the downsides of overscreening were not assessed. And then finally, there were two studies which similarly looked at algorithms that were used in electronic medical records systems. And they were used to determine which individuals were eligible for additional resources. Now, for the Obermeyer study, the primary outcome was eligibility for a care management program. And for the Thompson study, it was referral for education, additional treatment options, and care pathways. The takeaway from these studies was that they provided additional evidence that algorithms which do not include race can lead to disparities. So as example, Obermeyer studied an algorithm which predicted healthcare costs as a proxy for healthcare needs. As he outlined in the paper, this is flawed because the association between costs and health differs across racial and ethnic groups. So in summary, for our key question one evidence, the effect of algorithms is complex. We found that some may have been shown to perpetuate or exacerbate disparities, some may reduce disparities, and others may have no measurable effect. Additionally, an algorithm may exacerbate disparities for one outcome, but then reduce disparities for another. What we also found is that disparities can be reduced regardless of whether race and ethnicity are utilized in the algorithm. And so, for example, when disparities are outlined and considered and used to inform algorithm development, they may reduce disparities, such as the example with the kidney allocation system and other algorithms within that category. And then finally, most of the evidence focused on non-AI algorithms. And also, most of the studies in our evidence base, and this is across our report, were modeling studies. So they did not examine the actual use of algorithms to manage patients, but rather algorithms were applied theoretically to patient data sets to evaluate how they would have performed if implemented. And this information is quite valuable as it informed our needs and gave us a sense of the landscape of the space. And with that, having studies that examine the actual use of an algorithm and the effect on patient outcomes, it will continue to be informative for this conversation. So I'm going to pass it over to my colleague, Brian, to continue discussing our findings for key question two.
All right, thank you. Thank you, Kelly. We were going to take out, so the question really is, we know that there's evidence that algorithms are associated with creating bias, with perpetuating bias, and sometimes with reducing bias. But what can we do about the bigger problem? What do we know about the possibility of engineering algorithms in particular ways so that we can mitigate the possibility of racial and ethnic bias throughout the spectrum in how they're developed, how they're validated, how they're disseminated, and how they're implemented? And so there's a lot of activity in this area, and we really wanted to focus as much as we can on the published literature. So we conducted, as part of the review, a search just for studies that actually tested some type of strategy that was meant to mitigate the possibility of bias in an algorithm. We found 49 studies, which you would note is a lot more than we were able to find for key question one, which was really very focused on finding a direct association between the use of an algorithm in practice and actual clinical or other significant outcomes. For key question two, we were looking a little bit more broadly for studies that had attempted some type of a mitigation approach and were able to show some type of outcome. And so we came up with 49 studies over this time period. As you see, the majority of them are modeling or simulation studies, and so they didn't necessarily test them in real-world practice, but they did use real-world data in most cases, often drawn from databases of large health systems or insurance companies and so forth. But there were a significant number of cohort and pre-post studies that we were able to track this data a little bit more accurately, and one RCT as well, which I think we were a bit surprised that we found any RCTs in the entire course of the review. And overall, the studies were pretty well done. Most of them were at low or moderate risk of bias. And so we were encouraged that there is a fair amount of decent high quality literature that has begun to address this issue. We put together a word cloud just to give you a general sense of what kind of clinical topics, because there's 49 studies here. We're not going to dig into all of the individual areas that we found in the way that Kelly did with key question 1, because that would be a little bit onerous. If you look at both the manuscript and the report, we go into further detail about all of those, and you can see an evidence map that actually lays all of this out in substantial detail. But just to give you a general sense, we'll talk about this at a higher level. But the majority of the studies were looking at kidney function. And you may have noticed that in all of the studies that Kelly highlighted for key question 1, none of them actually talked about EGFR directly. And we thought that was curious. It was interesting to us, certainly, as a finding that with all the work that's been done in that area and all the commentary and all the movement towards rectifying the bias that has been identified, there weren't any studies that actually fit our criteria that actually were within the confines of our key question 1. But there were quite a bit of studies under key question 2 that sought to mitigate it. And so what we found was that much of the work that's been done more recently around this, and in some of the other areas as well, it was designed really to ameliorate the problem rather than to simply call out the problem or to find the associations there. So a lot of the studies dealt with kidney function, but there was a lot of other areas as well that's mimics fairly well, or mirrors fairly well, what we found for key question 1, including cardiovascular and stroke risk, screening, even warfarin dosing, and other things of interest here. So we really want to focus on what the mitigation strategies were, rather than the other ways that the studies break down by clinical area and so forth. And so we were able to identify really 7 broad categories of mitigation strategies that have been examined in the literature. And the most common approach was removing race from an algorithm. Obviously the primary example of that is EGFR, where the idea is that you take race out of an existing algorithm and you don't do anything else. You essentially keep the rest of the algorithm the same, and you see what the results are, testing it against a real-world population set. Not surprisingly, we found that this was largely an EGFR. We will get into this a little bit more in the next slide. But we also found that there are other ways to address mitigation. One of the things that we did find in a few studies was that you can replace a variable, which is, say, you take one out, but you actually drop something in its place. And this is of particular interest, I think, to our team as well as to a lot of folks doing work in this area, because one of the key questions, as Shazia alluded to, is that race can be a meaningful indicator of something, but it's not biologically the relevant variable in these algorithms. So what is it a proxy for? And so if we can identify better proxies for what race is able to approximate, then we might be able to improve both the quality, the fairness, and the accuracy of these algorithms without perpetuating stereotypes going forward. So we did find some studies that attempted to replace race or something else with another variable. Sometimes these were clinical indicators, sometimes they were genomic markers. In 1 or 2 studies, we found actually that social determinants of health or similar types of measures were used to replace race. We also found some studies that added race in. This is obviously a more interesting phenomenon and raises some ethical questions as well that we won't address too directly. We can talk about some of that in the Q&A if you'd like, but we don't address that directly in the report. But there were some studies that added race in an attempt specifically to address a disparity that was already known to exist. Often this came about in the context of being able to allocate resources appropriately and so forth. So we did find a few studies that did that, as well as other studies that added other variables that were not race-based, similar to the second strategy I mentioned above, where variables were added in and other things were not taken out. So all 4 of these are sort of discrete, where something was put in, something was taken out, or something was swapped in for something else. And those are the majority of the studies that we found that attempted to mitigate some existing disparity. We also found some more technical approaches. So algorithmic recalibration was something that was attempted in a few different studies. Typically, this means in practice that a group of developers will take an existing algorithm, look at the baseline data that was used to develop it. One of the criticisms, as we know, of many of these algorithms historically has been that they were derived from data sets that were not necessarily the most balanced or representative populations across, for example, the United States. And so they recalibrated using a different set of data that was more evenly representative of the population, and they found somewhat different results in terms of how the algorithm would then be constructed. And so there are some studies that report on those results. We found a few studies that actually went in sort of the opposite route, which is to take an algorithm and determine after a variety of statistical approaches that the fairest way actually to reduce disparities that were generated by the use of the algorithm would be to actually use the algorithm in two different populations. And so to stratify results or to stratify the implementation so that, for example, Black and white patients would be examined differently in the final analysis. And they actually found that in some cases that was a meaningful way of reducing disparities. And finally, there were some statistical adjustments that were used. I won't get into these in any great detail. Most of these are technical approaches that are beyond my personal understanding of both algorithm development and advanced statistics, but there are ways to adjust the actual parameters of how the algorithms are implemented in practice behind the scenes that make them a little bit more fair and use some newer techniques and approaches. We will dig in a little bit for just a couple of minutes into one key example here, and we'll look at the studies that did in fact remove race from EGFR and a few other examples, so you can get a sense of what we found in a little more detail. So there were 21 studies, as you see, that removed race specifically in the context of EGFR for kidney function. And what you see on the right side there is what the effect was on the disparities in outcomes, with green generally indicating an improvement in something, something that we find desirable, so a reduction in mortality, for example, or an improvement in the quality of antibiotic dosing. The red cells generally indicate something that is undesirable, which is to say that something like combined kidney and liver transplant is less accessible or less available to patients who in this case are Black. And we kind of color coded it partly because it's a bit tricky, because sometimes what's an increase is a good thing and sometimes what's an increase is a bad thing objectively. So the color coding is meant to really convey a sense of what is objectively preferable from a patient perspective. What you see here really is, as a key takeaway, is that the impact of a mitigation strategy, much like the use of an algorithm itself, can vary tremendously, even within a particular population and even within a particular algorithm. And so it's really challenging to make decisions about how to attempt to mitigate these to mitigate the biases that are inherent in the use of some of these algorithms. And so EGFR is certainly one of the classic examples here, where you see that removing race definitely improves the opportunity for Black patients to be eligible for kidney and liver transplants separately, but it actually may reduce their opportunity for those patients who would be eligible for a joint kidney liver transplant. It generally improves the accuracy of identifying the severity of their kidney disease. It may improve the ability to get certain types of pharmaceutical treatment, but it may also lessen the opportunity to get other types of treatment. And so, for example, there's a study that looks at cancer therapy access and how patients who were reassessed using an EGFR that did not include race became less eligible than they may have been in other circumstances. And so there are trade-offs to be had with mitigating an algorithm, in the same way that there are trade-offs in using an algorithm in the initial stages. And so what we really found interesting was that you have to think carefully when you're introducing a mitigation strategy that it will have an impact most of the time on something concrete in terms of patient outcomes, but deciding exactly what kind of outcome you want to affect and how, and knowing what those trade-offs are, requires a lot of consideration and a lot of balancing carefully of potentially opposing perspectives and needs. We also see here that it went beyond EGFR in terms of removing race. So there are some studies that looked at it in lung function, in terms of lung cancer screening as well, risk for postpartum depression. So there is a lot of activity going on in this space that we thought was interesting to highlight. What we did struggle with a little bit, I'm trying to adjust the slides. There we go. Is that when we're discussing these trade-offs, there's really no clear indication of whether one strategy is inherently preferable to another, or whether a strategy, any kind of mitigation strategy, will necessarily improve one type of outcome at the expense of another. And so, in terms of overall takeaways, it's a challenge, frankly, to decide what to do next. And that's really our key finding, is that there's substantial heterogeneity in terms of what was looked at from these mitigation strategies. There's a lot of populations and clinical conditions. We found, in the same way with key question 2 as we did with key question 1, as Kelly mentioned, that these are traditional algorithms. We really found virtually nothing in the entire systematic review that addressed AI generated or AI assisted strategies, both for developing algorithms as well as for mitigating the bias. There's a ton of work being done in this area, there's no doubt. And we've had conversations with a lot of the folks who are doing this kind of work. But the parameters of our study really sort of limited ourselves to studies that had made some kind of a comparison and presented the outcomes we were looking for. And frankly, the work that's been done, especially in the AI space, just hasn't reached that robustness yet in terms of being reportable in our review. And so they're traditional algorithms that are well embedded in clinical practice. And so the traditional solutions that have been developed to mitigate these things are really where we're able to focus on. But there's so much more work yet to come in terms of AI and other tools. We found generally that mitigation strategies do improve algorithmic accuracy, at least those that are reported. And we do assume that there are lots and lots of studies that have been conducted, especially within health systems, insurers, and elsewhere, that attempted to mitigate a bias and found that really nothing happened and probably are not published. And so there is some bias in terms of the literature that's available. But the published studies do show that mitigation does improve algorithmic accuracy. But what does it do for disparities? We're not really sure, because most of these studies don't necessarily go as far as to be able to bear that out in the long term. They use inference or they use simulation in order to estimate that effect. And finally, the modeling studies in general don't really reflect all the biases that occur when you implement an algorithm, the way it's translated into practice, the way it's disseminated across health systems, and the way it's implemented in the real world. And with that, we will wrap it up, and I will just mention that if you look at the report especially, as well as the manuscript, but the report especially goes into depth about a number of other questions that we did look at that were a bit beyond the scope of what we wanted to present on today, but do present some interesting context about the bigger picture, about the perspectives of key stakeholders, and about implications for a lot of different stakeholder organizations, as well as the work that's being done by a number of organizations, which we didn't touch on. But in terms of mitigation especially, you're probably all aware that many leading organizations, both in the US and around the world, have been trying to address this issue head on for the last several years. And a lot of fun activity is going on, frankly, that's worth trying to follow if it's of interest. But we addressed that a bit in the report, but didn't get into it so much today. But there's so much work that's being done in the space that I strongly encourage you to take a look at those types of things. And a lot of that is highlighted in our full report online. And with that, I will turn it over to Jen.
Great. Oh, did you have some, I think there were key takeaways and the next steps, or did you want me to take over, Brian?
That's right. I'm sorry about that. I forgot that
That's
was
okay.
at the end of this section.
All right.
All right. Just the one more slide, I think. Yeah, so just from a methodological standpoint, a couple of other things to note, that many of the studies were excluded because they only presented information on intermediate outcomes. They we required everything to include clinically relevant outcomes in order to narrow our scope sufficiently so that we could actually do the work in the amount of time that ARC had contracted with us to do. We had 63 studies in the entire report, but there are far, far, far more out there that were sort of relevant to our question, but didn't meet our stricter criteria because we couldn't have possibly looked at the thousands and thousands of studies that presented on a variety of intermediate outcomes that would be of interest. And if you wanted to take a deep dive, if you represent a particular society or particular clinical specialty, there's a lot of work that might be done in your area that isn't reflected as well in our work, but might be of interest. The evidence base generally is mostly retrospective cohort studies and modeling. There's not a lot of RCTs or even controlled prospective studies, and we do call in our report for more work to be done in that area. And I think ARC and other organizations are looking towards ways to fund that movement forward, and so that we can learn more about what's going on. We know in general that algorithms can reduce disparities. They also can perpetuate them, and they can exacerbate them. And it's highly, highly context specific. This is true both of the way algorithms operate in practice, as well as attempts to mitigate them. We found generally that it's very, very hard to make general overarching statements about the relationship between algorithms and disparities, because it is very context specific to the population, the setting, the outcomes that you're choosing, and the construction of the algorithm itself. And really, including race does not always cause harm, and there is quite a lot of spirited debate in the policy field about what to do in terms of using race and ethnicity. And so how do we use race is really important. And so understanding intentionality and how that's applied in practice is really significant. And when we looked at the studies more carefully, we found that many of the studies actually did identify, especially on the mitigation side, that they were attempting to use race in a particular way in order to address a problem, or that they were thinking about it in a particular way with a recognition that race isn't necessarily the biological cause of something, but might be a proxy for something else. And so looking for that kind of language and looking for those types of understanding of the problem, we think is really important going forward. In the older literature, of course, that's rarely something that is described in any depth, but more recently, people seem to be more frequently including that type of information in their studies. And it's important to think about. We like to say that algorithms involve choices that are made by humans, and they're not just generated by the data. They're not just spit out by the computers. And even with AI, they're not purely a product of some magic black box. They reflect real choices and real trade-offs and understanding of how these things operate, and those things all come into play. And it's really important to think about those things if you're in a role where you are developing algorithms, where you're using them, where you're applying them, or where you're evaluating them. It's important to understand how all of that fits together. All right. In terms of next steps, a few of the things we call for in the report pretty directly. There's not a lot of transparency, frankly, in how all of this work is done. We found several dozen studies, and even those were not always very clear in terms of what they describe and how they present some of their data or the rationale for what they were doing. A great number of algorithms, as you probably know, are not simply the work of researchers and health systems. They are developed by electronic medical record companies. They're developed by insurers. They are used in all aspects of our healthcare, and virtually all of us are affected by these things in ways that we don't always see. And we had conversations with some of those developers about some of the mechanisms that go on behind the scenes, and there's very little transparency in the process, unfortunately. And even with sort of the backing of ARC asking us to look into this through a request from Congress, we were able to poke very, very little, shine very little light on what was going on behind the scenes. And so there's a need for much more transparency from everyone involved in this kind of work. There's certainly a need for greater diversity in terms of how patients are recruited for clinical studies, of course, but also in terms of how they are included in the research teams that do this kind of stuff, how they are brought into leadership teams in terms of developing algorithms, in terms of testing them, implementing them, and evaluating them as well. And just to sort of anticipate some of the future issues, the guideline space is no different ultimately than the algorithm space, and the same is true when it comes to developing teams that work with guidelines and use algorithms in different ways. We found that very few people really know what's going on. All of us on the call today are sort of self-selected people who care already about this and probably know more than most about any of these issues. Patients are virtually completely unaware of how this operates behind the scenes, but physicians, frankly, are also mostly unaware of how most algorithms operate on a day-to-day basis. They take for granted the fact that if their electronic medical record or their specialty society endorses a certain thing or puts something out into practice, that it's been vetted properly and that everything lines up. And frankly, issues of disparities or bias are simply not usually front and center in their minds. And so they just aren't aware and they don't think about these types of things. And so we encourage everyone to think more carefully about these issues, to center these issues much more, but to also recognize that most of the folks involved in healthcare simply don't know very much about this and are unaware of what's going on. And frankly, beyond algorithms, as I mentioned, guidelines and federal policies and insurers and health systems are using algorithms in many, many ways that we don't always see or appreciate or have much influence over, frankly, but that these biases have ways of amplifying very quickly if we're not aware of these things and we're not prepared to think carefully about what the implications of all of that is. And so now I think I can turn it over. There we go. I'll turn it over to Jen. Thank you.
Great, thanks so much. I'm going to share my slides as I'm pulling these up. Just want to thank GIN North America for this opportunity and creating a platform for us and their commitment to continuing the dialogue around health equity. So thank you. And thank you, Brian and Kelly and Shazia, for a really great talk. And I think in some ways also sets up a lot of sort of the key key issues that I would like to cover for the last part of this talk. So I'm going to use the same structure that my colleagues did and briefly set up the background and process of that we use to develop some guidance that we put together for both reviewers and guideline developers to consider both the risk of bias and then fairness of what we call race-aware or race-based clinical prediction models. And then I'm going to introduce these two tools that we put together, the CARE CPM or Clinical Prediction Model tool, and then the Fairness Discussion Guide. And then I'll wrap up with some closing comments. So the two pieces of work that I'll be discussing today, we started in 2022 for the U.S. Preventive Service Task Force. I just want to acknowledge that this work was led by Corey Evans at our EPC. And the aim for this initial work was to develop guidance for the task force, as well as the evidence-based practice centers that support the task force that they could use to both evaluate algorithmic bias and fairness considerations for topics and recommendations involving race-aware clinical prediction models. And we realize that some of this guidance that we put together for the task force can be applied or can be used by other guideline developers and systematic reviewers as well. The second piece that I'll be talking about today builds on some of this initial work that we did for the task force. And this was a more robust development of additional questions that are specific to assessing risk of bias when race, ethnicity are included in clinical prediction models, or honestly, when they're not included in clinical prediction models. And I want to acknowledge that this work was led by both Shazia, who you heard from earlier today, and Corey from our EPC. So for algorithmic bias, we developed signaling questions that map to PROBAST, which is, if you're not already familiar, a critical appraisal tool for risk prediction and prognostic studies. Then we piloted these signaling questions on race-aware models using clinical preventative services, because that's the purview of the U.S. Preventative Service Task Force. And then using an e-Delphi or modified e-Delphi process, we obtained consensus on the signaling questions, that these were tested for feasibility and sort of inter-rater reliability. And then ultimately published this critical appraisal tool called CARE CPM that could be used as an extension to existing critical appraisal tools, and specifically PROBAST. For the fairness guidance, we initially did a deep dive and a synthesis of the foundational literature to really ground key concepts and guidance to date on fairness considerations. And then we developed a discussion guide that could be used by decision makers or guideline makers through a qualitative evaluation of potential threats to fairness when actually implementing a clinical prediction model or a risk prediction tool. And just this fairness guide has not yet been piloted, but it is being considered for piloting by the U.S. Preventative Service Task Force. So you've already heard a lot about algorithmic bias, but what do I mean when I use the term fairness? So I want to just acknowledge up front that bias and fairness are concepts that are addressed in a host of disciplines beyond medicine and healthcare, including ethics, law, insurance, finance, computer science, machine learning, psychometrics, etc. And so the multidisciplinary character of these terms has led to, I think, a proliferation of the terminology and definitions for these terms. And particularly for fairness, there is no single agreed upon definition of fairness. And there's many definitions, particularly the mathematical ones, that can be conflicting, internally conflicting. And so for the purposes of this work, we really began with a framework that is quite elegant, grounded by the work of Paulus and Kent, which we refer to in our full report, that really delineates algorithmic bias and fairness. So to be clear, we are not referring, when we say fairness, to the quantitative or mathematical criteria around fairness. We are talking about sort of a conceptual definition of fairness, that is, do decisions based on clinical models or algorithms create discriminatory or unjust impacts across different populations. So it really is a conceptual treatment of fairness, which I think is incredibly important as we apply clinical prediction models. So in contrast to algorithmic bias, which can affect model performance outcomes, fairness really is addressing what are the downstream health outcomes. Algorithmic bias is inherently a narrow and technical concept that's intrinsic to the model itself, the model development and model validation, whereas fairness is broad and normative and is really extrinsic to the model, really has to do with the application of the model in practice. Algorithmic bias, we believe, is best assessed by reviewers during, for example, the conduct of the review that might support a guideline, whereas fairness is best assessed by the guideline developers, taking into account a larger body of evidence and really the clinical decision-making context that the model is being applied or being used in. So next, I want to introduce the CARE CPM model and the discussion guide. So in the next 4 slides, because I know the slides will be circulated or available later, I list out all of the signaling questions, these extension questions, but in the interest of time, I'm going to focus on a couple examples. And I want to just also note that the numbering of these questions seem a little bit odd, but it's because they are mapping to existing questions in that PROBAST critical appraisal tool, which this is meant to map to. So in the first domain, which addresses participants, we have 3 questions, and I'm going to focus on the one in the center, 1.3b. And this is asks the questions, Was the racial and ethnic distribution of the population in the development data similar to the distribution in the target population? So the population that you would like to apply your model to. And it's really meant to address representation bias, which occurs when estimates from one population are inappropriately extrapolated to other populations. So specifically for race and ethnicity, underrepresentation of various racial and ethnic groups may actually contribute to differential predictive performance. And so the population distribution from the development data to get a sense of, how applicable or how representative it is could be compared to, say, recent census estimates at, a national or state level. And that is important to understand the representativeness of the underlying data to understand if there is potentially representation bias. So there are two questions in the predictors domain. And again, these domains map to PROBAS that has these domains. And I'm going to focus on the second question here. So item 2.5, which gets at was differential missingness of predictor data in racial and ethnic groups reported. So this question really gets at selection bias. So for example, missing data may be associated with the contact that an individual has with the healthcare system, which in turn reflects patterns of care and potentially structural racism affecting patterns of care, so that bias can actually be further exacerbated in the context of differential missingness across groups. So basically, the more missing data there is in a population, the more selected or less representative the development data become. And we offer some guidance, as does PROBAST, on sort of the preferential way of treating missing data that can help mitigate some of this selection bias. But ideally, you wouldn't have significant differential missingness of data. So for the outcomes domain, we have two questions. You'll see a grayed out question up top. That refers to the original question in PROBAS that 3.4a maps to. I'm going to focus on the last question listed on the slide as the example. And this question is, were proxy outcomes avoided as the predicted outcome, where the proxy may be subject to encoded bias? So a lot of jargony terms in there. But this question really addresses what we call label choice bias, which is a mismatch between the ideal target of the algorithm and what it should be predicting, and a choice of a bias proxy variable, which the algorithm is actually predicting. So I want to reflect back to that example that Kelly mentioned by Obermeyer, because that is a great example of the label choice bias. And in that example, healthcare cost was being used as a proxy for health, overall health. And the issue with that is, healthcare cost as a proxy for health is understandably problematic, because it really, healthcare cost reflects access to care rather than true health needs. And so, I think that is an elegant example of why it matters, which variable that you're using. So the final domain in the PROBAST critical risk appraisal tool is the analysis domain. And there are 3 questions or signaling questions or extension questions that we developed. I'm going to focus on the last one on this slide, which is item 4.7a. And this question asks, were relevant model performance measures evaluated appropriately in racial and ethnic groups? And how does model performance compare among racial and ethnic groups? So ideally, both calibration and discrimination should be assessed and reported separately by racial and ethnic group. And this includes if they're using race as a risk variable, or a model is not including race as a variable. But this will allow for meaningful comparison across groups. And so, for example, discrimination. So when discrimination can be higher in samples that have greater population variability, while differences in discrimination measures are expected to differ across different groups, accurate models are always going to have good calibration across the group. So really important for them to report both discrimination and calibration, which isn't often done, but I think now increasingly with the reporting guidance that's out there, the reporting on this is much more robust. You might have to dig into supplemental papers or, a supplement or an appendix to the paper, but, we're looking for this data to be able to assess model performance across groups. So I mentioned earlier that we pilot tested these questions on a handful of clinical prediction models, and we found that the tool was very helpful in articulating the limitations of the clinical prediction models that we looked at. And it can help really understand the mechanics of the model, but it adds significant time to the critical appraisal process. And often you're looking at additional publications. And as I mentioned before, into digging into supplements as well. I think the other thing that we realized, and we know this from other critically appraising other clinical prediction models, is that many of the clinical prediction models that are published are at high risk of bias, primarily due to the analysis domain. And then when we apply these extension questions, they're already at high risk of bias, and then we apply the extension, and so they're still at high risk of bias. So I think the value is less in terms of assigning the actual saying low, moderate, or high risk of bias, but again, much more helpful in actually articulating what the specific limitations of the models are with respect to perpetuating algorithmic bias. So I list in this table a few examples and from that are in the clinical prevention sphere. The PCE is the pooled cohort equation to predict cardiovascular risks, and then FRAX. This is the US FRAX because that is the one that includes race, and Q fracture. And both of these clinical prediction models are used to predict osteoporotic fracture. And you can see in these two examples that, again, that most of the domains, for the FRAX and Q fracture were high risk of bias. PCE did perform better, but because it was at high risk of bias for the analysis domain, was deemed high risk of bias. It doesn't mean, when we say high risk of bias, it doesn't mean that it should not be used, but it should be acknowledged that there is potential bias in these tools. So this begs the question, in the setting of having clinical prediction models that are potentially at high risk of bias, what are other ways of mitigating the potential negative effects of imperfect models, which we're always going to have a world of imperfect models. We can make improvements, but we're never going to get to perfect. So I think this really brings us to the concept of fairness. And again, this is the conceptual definition of fairness. So do decisions based on these models create unjust impacts? So for this, we developed a fairness guide that offers structured prompts for considerations when recommending a model. This guide is meant to be used after risk of bias has already been assessed. And the emphasis, and I want to emphasize that the guidance that we developed here is not a formula to say, do this or don't do this. It is rather a structured way of thinking about how one might want to implement an imperfect model And I think it's important to recognize that, again, models are imperfect. They may have inherent biases, and models also exist within a larger implementation context. So again, there's no equation in this discussion guide, on saying how to do, but it again helps one or a guideline recommendation group or a healthcare decision-making group to decide how they might want to frame the implementation or recommendation of a specific model. So this guide has 19 questions across 5 domains. It's a background domain, a clinical decision context domain, model performance limitation, implementation and thresholds, and research and policy gaps. So again, in the interest of time, I'm just going to share an example question from each of the domains. The full text link to this report that has the full discussion guide is listed in one of the previous slides. So for the background domain, there's just one main question, and this really is understanding if there are known inequities in access to quality, inequities in access to or quality of care, or inequities in health outcomes that are relevant to the condition. For the clinical decision context domain, there are 5 different questions, and one of which is to understand the extent that the prediction model is being used for resource allocation versus rationing. So this idea of how scarce or how limited are the resources that are being allocated in this sort of clinical decision context. So I think it makes a difference if a clinical risk prediction tool is, for example, predicting a risk estimate if you should prescribe aspirin or not, versus if they're getting an ICU bed or an organ transplantation. So that sort of clinical decision context, is important to consider. Under model performance and limitations, so this domain really pulls forward a lot of the understanding during and of the limitations of the model from the critical risk appraisal. But it also includes some additional considerations, one of which is understanding if there is information to inform differential performance in models that include race and ethnicity as a predictor compared to models that don't. So you heard earlier from both Brian and Kelly that it's not that including race, ethnicity as a predictor is necessarily problematic, and sometimes it can improve existing health disparities, or the decisions made on that model can improve, but sometimes it can exacerbate, the decisions made on that model can exacerbate health disparities. So it's really important to understand, the difference if there are multiple clinical prediction models, those that include race and ethnicity as a predictor versus those that don't, and not make the assumption that the ones that don't are inherently better. So the implementation domain has the largest number of questions. It has 8 different questions, many of which address the inherent uncertainty of model predicted risk estimates and what thresholds or cutoffs are used in clinical decision making. So the sample questions listed in this table really get at if there are alternatives for estimating risk, using absolute cutoffs or using differential cutoffs for different groups of people, and how best or what are the methods or considerations around communicating uncertainty of risk. And then the last domain in the discussion guide has just one question, and this is around research and policy gaps, which asks, are there important evidence gaps that should be addressed to improve the assessment of risk in specific populations to equitably guide care? So that's a very 10,000-foot look at the discussion guide, as well as the extension questions for the critical risk appraisal tool. I think our takeaways from our work really are that guideline developers should at least attempt to address algorithmic bias in risk prediction models that they're recommending. Systematic reviewers can use these equity relevant signaling questions to critically appraise both race aware, and I'll put in there non-race aware clinical algorithms, to articulate some of the biases that are inherent to these models. And I think in the context of imperfect models, the guideline developers, when recommending specific models, should really think about what needs to be adjusted on the implementation side to address the limitations of recommended clinical prediction models, given their limitations. So I think it's fair to say that the critical risk appraisal tool, the CARE CPM tool, would benefit from further application to a more diverse set of clinical prediction models. I mentioned earlier that the fairness discussion guide is under consideration for piloting on one of the topics for the U.S. Preventive Service Task Force. I also think there's some the understanding in this field would benefit from really a larger discussion or dialogue on how best to compare clinical prediction models with usual care. I think that even though clinical prediction models may be biased, usual care has our biases or assigning risk or understanding risk or allocating resources without clinical prediction models, has implicit bias when we as clinicians or even health systems make decisions. So to understand how clinical prediction models compare with not using clinical prediction models or whatever the usual care is, maybe it's just using one or two variables. And then I think there is this philosophical question, which is, the inclusion of race ethnicity in clinical prediction models, is if inclusion of race or ethnicity as a variable improves the predictive accuracy, meaning improves the calibration of the model, is that enough to justify including it in the clinical prediction model? And I don't think that there is an easy answer to this question. And there's intelligent people who fall, on both sides of sort of this philosophical discussion. So I think there are a lot of next steps in this field, but there's also a lot of work being done. So it's kind of an exciting time. So I'm going to end my slides here. And I think we've left a little bit of time for questions. I apologize, I went a little long.
Please don't apologize, Jen, and thank you to everyone, all the speakers. That was really, it was so much information. It was so important and useful, but you really did distill it down nicely for us. So a reminder for everyone that you can drop your questions into the Q&A box in the Zoom toolbar. So again, thank you. I think, in some of the next steps that were noted about understanding the role of racial and ethnic bias beyond the algorithms, I wonder from the panel, what do you think are specific insights from your research that may be most pertinent or applicable to the development of systematic reviews and clinical guidelines more broadly? Any thoughts? Oh, I think speakers, if you want to turn your videos back on as well, you can for this one.
Kate, can you ask that question again? Are you asking for what the sort of the distilling the key takeaways?
Yeah. If there are specific insights or learnings from your research that if even those of us in the audience who might not be developing or working with algorithms specifically, but that we could apply and take home and think about for the more broad work of guidelines and reviews.
I'll start, and then everyone else feel free to jump in. But I would say one of the takeaways from the work that we did on the ARC report was really sitting with the reasoning behind the choice and the use of race and ethnicity, how it was described within, individual studies, and then what our approach was and how we were considering it in our discussions and in our background information and the framing of what we really wanted to see or try to determine at the end of the report. So, for example, as we mentioned, some examples of how is it being used? Is it being used to improve this algorithm specifically, or is it being used as a proxy and it may not be the best representation of what they're really trying to determine or gauge by using that algorithm? So I would say definitely intent behind the use and the framing of those demographic variables.
Thanks, Kelly. Okay. I think a few questions that are I believe are outside the scope of your specific work, but would be curious if you have comments or knowledge of what else might be going on. I know, Brian, you mentioned the role of AI, and so what do we know so far about the role of AI and machine learning and clinical algorithms and potential for bias?
Yeah, I mean, I'll say I'll speak to it real briefly, and then I'll see what other people have to say. I mean, it's really where everybody's focused right now, to be honest. It's where all the research and most of the activity and all the leading organizations that are thinking about this stuff are really focused on how AI is going to both negatively and potentially positively affect all of this work in the future. And so a lot of the work is, how can we prevent AI generated tools from, from reinforcing biases that exist in society because they're drawing off data that, represent populations and represent a status quo that is already, grossly unfair and unbalanced in many ways, and in healthcare no less than in any other field of research. And so there's a ton of work being done on how to examine that, how to define terms, how to create teams that are aware of this and safeguards that are built into the system. I think with healthcare, it's a little trickier in some ways, frankly, because a lot of the AI tools are still, I think, in their infancy in terms of how they're really going to be applied to a lot of clinical care, point of care decision making, and they're not really being tested out well. And I think a lot of the work is still yet to be done. And so, we think about AI in these broad abstract terms, and we're not always on the same page potentially as to what we mean by that. But there's so much activity, so much work being done. But at the same time, I think within the field of healthcare more narrowly, and in terms of decisions that are being made at the point of care, there really isn't a lot of a sense yet of exactly what's going to happen next or how it's influencing our care. But I think the takeaway is that anywhere that an AI tool is going to be used to drive decision making, to inform clinicians, to shape any of the care we get, there's potential there for existing biases to be exacerbated or for new biases to be introduced, and potentially for existing disparities to be addressed in a positive way too. But it requires real thought and care and intention about how those are being used.
I can.
Yeah.
Thanks so
Go
much.
ahead.
I'll just to echo one or two points, and also just to add that I think one of the biggest issues comes down to the lack of transparency in terms of what actually goes into AI and other algorithms that are being utilized. What are the variables? What does the data set look like that it was trained on? And I think that's really where we struggle, because an algorithm really is only as good as the data set that it comes from. If it's not a representative data set, if it's not diverse, if it doesn't include proxies for which we believe race to be a variable in that clinical context or condition, then it's very challenging to be able to replace race with a more precise variable as well. And I will share, I definitely will echo Brian's statement that that's where most of the focus is on. A couple months ago, the NIH hosted a workshop on, it was called Toward an Ethical Framework for the Use of AI in Behavioral and Biomedical Research. And I was asked to co-lead the workshop specifically on the use of proxy variables. And of course, race and ethnicity falls into that category. And what was interesting was that even as we discussed as a group, all of the use cases of harms and ethical considerations that came up, that examples that were given, most of them were not actually AI examples because there are so many non-AI examples like EGFR where we just know more about it. And that's because I think there's more transparency, more studies, more data out there. And so I think our review really, it did capture some AI algorithms, but I think to Brian's point, there's a lot of interest in there, but probably the area where we unfortunately know the least.
And I'll just, my piggyback comment is, you know, I think it's the same principles apply to evaluating an algorithm regardless of how it's generated, which is understanding intrinsically what are the limitations or biases within the model, but then also understanding the sort of fairness application of how, you know, the clinical context and the decisional context in which the model is being, or the estimates derived from the model are being applied. I think AI is particularly tricky for all the reasons that Brian and Shazia mentioned, and because of the lack of transparency and the iterative nature of these algorithms, and the black box nature of it is that it is more difficult to assess the biases. It's more difficult to assess some of the sort of those intrinsic limitations. But I think our framing of how we think of it, you know, and what we need to understand in order to make sure that these aren't perpetuating at a minimum, you know, disparities, and hopefully at a maximum minimizing them. I think the frame of how we think about it is the same, the inherent, you know, the basic principles.
Great, thank you. And what about other types of systemic and societal biases for other factors like sex, gender identity, so on? Do you know if there are related efforts or recent work or ongoing efforts to explore this? Or any comments on it generally?
Excuse me, sorry. There wasn't a component of what we reviewed for our evidence, but just even one of the examples that I shared had to do with the heart pathway and how there was non-adherence, some, you know, differential levels of non-adherence when it came to providers administering and following that pathway for women than for other patient populations or others. And so I think that just kind of stuck out to us as, okay, there are some, you know, potentially there definitely are some other issues that might be happening. We didn't necessarily explore those, but I would imagine that there is some research that's going on to even go beyond race and ethnicity, of course, and those factors, and then the intersection between multiple sociodemographic factors. So didn't mean to cut you off, Jen. Saw you.
No worries, nothing to add.
Yeah, I'll just mention it's a real big factor, and we talked about it a lot early on in our report about, you know, we wanted to focus on racial and ethnic disparities, but what about everything else? And we heard from a lot of stakeholders that, you know, you can't be too narrow-minded when you think about these things, because algorithms affect lots of different aspects of our identity if they're encoded in some way. And there are algorithms that we found, or that were at least that we're aware of, that weren't the focal point of our report, but that do, you know, include obviously gender being a key one, But religion, for example, has been used in some public examples of algorithms that might misuse an identity factor in key ways. And there are other aspects as well, ability, disability status, and a whole range of other things that where there are existing disparities potentially already in the health system. And there's interest in this area, I think. I think that race and ethnicity has risen to the fore for a variety of social reasons and because of the research that's already been done. But it's something I think that needs a lot more attention, and the conversation has to be pushed forward in that direction.
Thank you. I know we're at time, and I know, Jen, you have to run. I just want to say thank you, thank you, thank you. And I think that this work is so impressive, and it's certainly setting a model for future research on all of these factors, Brian, as you're saying. But these contributions are so important, and these presentations were excellent. So thank you all. Please join me in thanking the speakers, and have a great Friday.